Well, hello and welcome everyone to this next session of MycoClinics, run out of the MRC Centre for Medical Mycology at the University of Exeter. And we've got the subject for today's clinics is aspergillosis in specific patient populations. And we're very happy to welcome Dr. Simon Dubler, who's a consultant anaesthetist and assistant professor at University Hospital in Essen in northwest Germany, to talk to us about aspergillosis in critically ill patients. So before we begin, just to remind you about the parallel series for scientists and mycologists. This is Myco Talks. So there are two coming up, as shown here, 26th of June and 24th of July. So please do join these excellent Myco Talks, those of you interested in the scientific and mycology aspects. And also, just to make you aware, remind you about these online courses in medical mycology organized by the MRC Centre for Medical Mycology at Exeter. PG certificate, PG diploma, and MSc in medical mycology. So with that, I'll just introduce Dr. Simon Dubler. As I say, he's a consultant anaesthetist, assistant professor. He's interested in critically ill patients with respiratory failure and ECMO therapy, and research-wise, specifically in sepsis and fungal infections, especially invasive aspergillosis. He's the leader of the pathogenicity of invasive fungal infections working group at the University Hospital in Essen. And we're very pleased to have you today, Simon, to talk to us, and looking forward very much to your talk.
Yeah, thank you very much, Tom, for the kind introduction, and thank you, Jenny, for organization, and Adelia for doing all that. And I'm very happy to be here, and dear friends and dear chairs, I try to show you my presentation now. We'll see how this is going. Tom, short feedback. Do you see my presentation?
Yes.
Yes. Very good then. So let's start here. The topic of my today's talk is invasive pulmonary aspergillosis in non-immunosuppressed, critically ill patients. And Tom already talked about what are we doing here in Essen, what am I doing the whole day? We are the Department of Anesthesiology and Intensive Care Medicine. We are an over-regional RDS center, and as you heard from Tom, I'm interested in ECMO therapy. So I treat a lot of patients with respiratory failure. What you see here was a picture done or taken during the COVID-19 pandemic, a picture that is known for a lot of you people, and we see an ECMO in the middle and the critically ill patient. That's where we are. We are in Western Germany. That's Essen. We can see Exeter on the map as well, and we are an ICU which is exclusively run by anesthesiologists. We have 22 separate bedroom. We do around 100 ECMO therapies a year. We are part of the German Infectious Disease Center. We are an excellent center of HCMM, and we have an ECMO team who's available 24/7, and we are having an ECMO retrieval team available 24/7, as I said, and sometimes we fly when the weather is good and retrieve patients with respiratory failure on ECMO. This is what we do. And as Tom mentioned, I'm interested in Aspergillus infections, and that's not, let's say, I'm not the only one who sees it that way. As you all know, the WHO proposed this a few years ago and put Aspergillus fumigatus in the critically group of pathogens to guide research and development and cause for public health action. So we are not alone today with that. And I just show you another slide. That's a very old one from 2009 from Jean-Louis Vincent, who is very interested in sepsis, one of the leaders in sepsis research, and he did that very nice paper a couple of years ago and looked at over 10,000 patients, and what he saw is that the third most common pathogens in intensive care are fungi, and next to bacteria, and the Aspergillus is the second most common detected pathogen in this special group of patients. And you've probably seen that published last year from David Denning, that invasive aspergillosis is a real problem. And what struck me is we all thought in the last years that invasive aspergillosis is only a problem in the immune suppressed patients, like lymphoma, leukemia, stem cell transplant, etc., etc. But what you can see here in hello blue is invasive aspergillosis in ICU patients. So that's exactly the patients we treat every day. And on the right side, you see the massive mortality that comes with invasive aspergillosis in these patients. And I just want to present a case who presented a couple of weeks ago. It was a 43-year-old gentleman, no prior comorbidities, and he suffered a high velocity car accident, was polytraumatized, and technical rescue for over 2 hours, and all was very complicated. But he made it alive to the clinic and suffered multiple fractures. He fractured his right femur, his spine, multiple locations, crushed kidneys, lung contusion, and he presented with septic shock and developed a severe RDS just in development of 48 hours. And we put him on venous ECMO therapy. And when we look at the CT scans of this patient, you see he was an obese gentleman, and you see that he was already been to theater with his spine, and you see that his left lung is total consolidation, and there's a little let's say healthy lung left on the right side. But if you take a closer look, you won't say that this gentleman suffered from any typical, let's say, fungal infections like what we all learned, like halo sign or signs like that. And when we take a closer look on the microbiology samples of these patients, you see that even after day 2, so very short in the life of these patients, we saw that he was Aspergillus PCR positive. He had a galactomannan in the bronchial alveolar fluid. That's what BALF stands for. With 2, he was also culture positive with Aspergillus fumigatus just on day 2, and the repeated samples on day 4 just showed the same thing. And then he also suffered from staph sepsis on day 17 and reactivation viruses on cytomegalovirus and herpes virus. And you could imagine that we started this gentleman very soon on voriconazole therapy on day 3. We did the bioassay, which showed good values. This gentleman died due to multi-organ failure due to septic shock just on day 17 after arrival, and we can talk about this later. Who of you would have started this gentleman on voriconazole, or who would say, I'm not sure if this patient even had an invasive pulmonary aspergillosis? We can talk about that later. And what struck me and the people in my working group is how is immune response to Aspergillus fumigatus working, especially in this critically ill patient group. And that's a very nice review from Paul, I guess, who's here with us today. And it's very complicated, the immune response of Aspergillus fumigatus. But what I want to show you here, not very much into detail, that it's very about innate immunity. So macrophages, neutrophil granulocytes are playing a crucial role when it comes to immune response to Aspergillus fumigatus, and especially neutrophil granulocytes have a special role, because they're not only orchestrating or killing conidia, what you can see on the right side, which just engulf them and kill them. They have a role when Aspergillus fumigatus gets to terminating and gets to hyphae. They swarm and do netosis and work together and try to kill, or at least do a damage control to Aspergillus. So neutrophil granulocytes are very important and very interesting topic when it comes to research. And we talked about sepsis in the beginning of my talk, and just to remind you that sepsis is a real killer. Over 11 million people die due to sepsis. Every few seconds, somebody dies in the world of sepsis. And when you look at neutrophils in the sepsis, you see that there to put it on the right side for you, that neutrophils are really affected by sepsis, and they can't do their job. Probably they have decreased reactive oxygen species and decreased expression of adhesion markers and molecules, and so they're really hampered due to sepsis. And we did a little study 2 years ago where we just asked ourselves, what's the defense mechanism of patients with sepsis? And what we do is really easy. We did a co-incubation of Aspergillus fumigatus conidia and neutrophil granulocytes and put them together for 16 hours. So you might say, wow, 16 hours ex vivo, that's a pretty long time. But what we could see through flow cytometric analysis, that they still work after 16 hours. And what you see on the left-hand side is the inhibition potential, what tells you, because we did a XTT analysis of this co-cultures, so we saw how many living cells are there after 16 hours. 100% would mean there are no living Aspergillus hyphae cells after this 16-hour experiment. And then you see out on controls, the gray bar, controls mean there were just people of the lab, people of the ICU. their neutrophil granulocytes did a very good job in killing Aspergillus fumigatus, where patients with sepsis, I mean, there were only nine patients, but these neutrophil granulocytes did a very poor job in defending Aspergillus fumigatus, and we now taking this forward to the next experiment where we actually look closer to the phagocytosis, because we think, and there are data that show us that phagocytosis is a key component when it comes to Aspergillus defense and is hampered during sepsis. So we're actually taking a closer look at that, and we see where this is gonna take us. And we talked about this critically ill gentleman with no prior comorbidities, and he suffered from ECMO. And a few years back during the pandemic, we looked at patients. That's a different topic, different pathology. We looked at patients with COVID-19 associated pulmonary aspergillosis and asked ourselves if dexamethasone had any influence on outcome, which it hasn't. But the thing I wanted to tell you here is not about the dexamethasone, it's about the ECMO therapy, because we saw that patients in the kappa group had over 50% of these patients suffered from ECMO therapy. But we wouldn't say or wouldn't propose that ECMO therapy is increasing the risk of getting invasive pulmonary aspergillosis. We just say, okay, these patients are just the sicker patients because they need ECMO therapy. They need more kidney replacement therapy. They need more intubation. But still, it's an interesting thought if the ECMO as a procedure may have any impact on neutrophil function or invasive pulmonary aspergillosis. So that's why we put us together with Matthias Gunzer, one of our immunologists, which may have heard of. And what we did is we isolated neutrophil granulocytes of patients with ECMO therapy and without ECMO therapy, and made an image acquisition with the complex eye. That's a multi-lens array microscope that allows phenotypic high throughput migration screens. So it's a migration analysis and for clinical experimental setting. And the complex eye was designed to acquire video analysis of multiple independent cell samples simultaneously in a multi-well plate. And what you see on the right side is I just want to show you the dots with ECMO, no ECMO, ECMO, no ECMO. I mean, they were simulated with MLP, PBS, CXCL1, CXCL8, but it doesn't matter where you look. That obviously didn't matter. I mean, the neutrophil granulocytes didn't care if they were running through an ECMO machine or not. And I brought you a picture of that, and it's very, very, very interesting, very funny to look at. If you see these neutrophil granulocytes migrating, moving around, and there's no difference between during ECMO therapy on the left side or after or even before ECMO therapy on the right side. You had an AI-assisted software that told us that there was no influence, which is very interesting because we thought that this oxygenator on this ECMO therapy, where these neutrophil granulocytes run through between 4 or 5 liters a minute, might have some impact on neutrophil granulocytes. So that brings us to diagnostic challenges when you think of our 53-year-old gentleman and who recently recently died. And if you look at the latest diagnostic workup for invasive pulmonary aspergillosis in the ICU setting, we can't make this diagnosis because this patient did not have any host factor. This patient was not feasible for biopsy on the ECMO, and the only thing he had, but we, as I told you before, we have to discuss this if this mycology samples really were showing invasive aspergillosis. So we can't really say that this patient suffer IPA and that we should start antifungal therapy. And just to remind you, that's the blood algorithm you all know from 2012. And if you do that on our patient, that won't get you any further. It's a bit better if you do the fund ICU consensus definition from last year. But on the left side, what we see here, okay, we know kappa, we know yappa, we know influenza, COVID-19, all that things we learned in the past years. But what about patients with sepsis? What about patients with septic shock? Why isn't that a risk factor? And if you look on the right side, which hasn't changed very much, is that the galactomannan in the bronchoalveolar fluid should be above 1.0, and we have to discuss this if this is the right threshold, because we did a little study back in the last hospital I worked in Heidelberg, when we looked at 69 patients who were on the ICU, and they all had a galactomannan of 1.0 or above. And we asked ourselves, do these patients really show that was a retrospective study? Did these patients really had invasive pulmonary aspergillosis according to latest consensus definitions? Or did these patients maybe showed aspiration because they were all surgical patients? And what was really interesting that more than half of these patients showed signs of aspiration. And when you look at these patients group where this is aspiration and people are the invasive pulmonary aspergillosis group, you see that in the aspergillosis group, they showed these classical risk factors: liver cirrhosis, solid organ transplantation, corticoid therapy. So we weren't probably that wrong with our work. And what was really interesting is if you look at the first values of the first bronchoscopy results, that in the invasive pulmonary aspergillosis group, it was as high as 4.5 in the median, which is like really, which is really high, and aspergillosis group is 2.0, so way above 1.0. And when you can see here, first-line therapy in 38% of the cases. So we can discuss afterwards if these thresholds for these kind of patients are too low when it comes to solid organ transplantation or critically ill patients. Maybe we need different thresholds of these patients when it comes to galactomannan. And what I wanted to share with you, which is very interesting, that when it comes to get better in diagnosis, what can we do? I show you this work from Matthias Gunzer and Christopher Thornton, where I thought he's located in Exeter as well. Matthias Gunzer, as I told you before, is located in Essen, and what he did with JF5, that's a monoclonal antibody labeled with 64 copper, as a PET tracer, and this binds to galactofuranose-rich glycoprotein expressed by hyphae only of all clinically relevant Aspergillus species, like Famigatus, Tereus, Niger, Flavus, etc., and forms the base of a novel lateral flow device for invasive pulmonary aspergillosis detection. And while the high accumulation of the murine JF5 based radio trace in the lungs is directly linked to the presence of invasive hyphae, at least in the mouse model, where you can see on the top right, and on the pictures B and C, you see the quantification of the in vivo radio tracer accumulation in the lungs 48 hours post injection, and in C on the other organs. And we actually wanted, because there's a humanized form of this antibody, and there are studies where people put that into humans, and we actually wanted to do that here in Essen, and we are really very looking forward to do that. But the German authorities ended this experiment because it could even get started. Maybe we would do another attempt very soon, just to do a humanized JF5 antibody in critically in patients. That would be a very interesting thing to do. And what I brought you today, a lot of you might have visited ESCMID this year, and just wanna share with you a few slides and what the future could bring when it comes to diagnosis of invasive pulmonary aspergillosis. And John Seng from Johns Hopkins showed us a presentation about the new PCR technology, used barcoded magnetic beads technology, which is able to do numerous pathogen detection of pathogen, not only Aspergillus like Mucorales, Fusarium, etc. And what was interesting, that if you look at this slide, what the performance of this assay was, together with positive culture, that the patient populations is again the immunosuppressed patient populations, like organ transplant, corticosteroids, etc. And I'm missing my critically ill, non-immunosuppressed patient. So before we start with the discussion, I just wanna run through quick through drug resistance. And at the ESCMID, I heard a very interesting talk of Maiken Arendrup from Copenhagen, Denmark, which a lot of you might know, and she presented the latest surveillance data of resistance of Aspergillus species. And what really striking is that we in Western Europe obviously have a lot of problems when it comes to azole resistance, with 34 and 46 variants, with 36% in Western Europe, where the North Americans showed as little as 7%. And was always very interesting, that there's obviously a lot of a big difference between European countries, where you can say the more east you go, or the more south you go, the less azole resistance you have. Where the latest data from Netherlands, I will show you that the next slide, are above 10%, where about here in Germany, compared to Germany, it's about 5% and stable. And my home country, Switzerland, has less than 2%. And she showed us this data, that the azole resistance in the Netherlands increased. I'm sure that Paul Verwey can talk about this afterwards what's the reason behind this increase. We just know from the talk from Mike and Arendrup that it might have something to do with the environmental route, and Peter Roth, which is already which is here today with us, published this paper, very nice paper this year, where they look at trends of acil-resistant Aspergillus fumigatus at our institution, and as an ECMM excellence in 12 years, and they found that almost stable MICs for itraconazole and voriconazole over 12 years in acil-resistant Aspergillus fumigatus isolates, in a total of 143 isolates, while occurring acil-resistant underlying mutations varied, with an increase in the proportion of TR46 and other types of CYP51A mutations. But it was probably stable over the last 10 years. And I was just want to finish with that slide. I asked ChatGPT, how do you see the future of Aspergillus diagnostics? And it was very, very interesting what it said. That it said that's the future of a futuristic hospital room, a portable diagnostic device, examining patients' breath, a 3D lung, AI support, analysis, doctors working on tablets in the background, supported by a decision assistant, which is very interesting. And we actually, which is really funny, that we are actually experimenting, or try to put on an experiment with a portable diagnostic device analyzing patients' breath. I can't tell you more on this stage, but I will be able to tell you hopefully in a few months about this portable device, if this had brought us any further. And with that, I conclude, and I'm very happy for questions, and thank the audience for listening.
Okay, thank you so much, Simon, for very thought-provoking talk. So please, anybody, feel free to put any questions for Simon in the Q&A box. We don't have any questions at the moment. I've got a few questions, but also I want to invite Paul Vauvet, who's on the call, if he has any burning questions he wants to take up with Simon. Paul?
Yeah, sure. Thank you, Simon, for this very interesting presentation. I think it really underscores the difficulties and the challenges we have to diagnose invasive aspergillosis, especially in this patient population. I think it was very interesting to see this difference between patients who aspirated and still have this positive Galactoma result. So I was wondering if you had any thoughts, especially if you see the trend that the mycology is becoming more and more important, if you don't have these host risk factors, if it would also be an option to look at host response, as maybe there are markers which we could use to help this diagnosis.
Yeah, thank you, Paul. That's a very interesting thought, and we definitely should take a closer look at this, how's the host defense on patients with these missing factors, because we know that liver cirrhotic patients don't have a good immune system, or COVID or influenza, but we don't know that in our not immunocompromised patients. And we actually tried to do that with this migration assay. I didn't show you this data, but we did a lot of migration analysis of patients with sepsis, but I can tell you this didn't bring us any further. So we need another tool or another pathway where we have to look how the immune defense of this patient is. Definitely.
Yeah, so that I think might be a way forward, that we, look at multiple markers. So we have, culture, we have galactomannan PCR, and there is a trend already, having this multi-marker diagnosis. And maybe if we find specific immune markers, maybe for epithelial damage or other markers, which might help us then to make the diagnosis. Because the question is, in your patient, do you believe in the end that this patient indeed had an invasive aspergillosis, because the galactomannan was 2, which might also then be due to aspiration?
Yeah, thank you for the comment, Paul. I mean, I told you about the technical difficulties on this crash, and if you ask the people who rescued him, we knew that this patient really lied in the grass or in the dump, probably with his face down on the earth. And what we think, that he was just like all over the place with Aspergillosis, that was just, in the mud, in the earth, and it was just colonized. That's what we think. I mean, we did, we put him on voriconazole because we were really scared that he dies. But we all, deep in ourselves, we didn't believe that he has invasive pulmonary aspergillosis.
Yeah.
And that's something we might take into account, that there are other reasons for positive galactomannan besides aspiration, accidents, stuff like that.
Yeah. Just to follow up on that, there's a kind of related question in the chat. Back at the start of the case, considering they had detectable BAL by day 2, do you think this is a true invasive infection? Well, I guess you've kind of answered that. How often is galactomannan positive in colonized patients without invasive disease? How sure can I be that the patient with a positive GM is invasive? Yeah.
Yeah, we talked about that's not easy. I mean, to say, and I'm interested in your opinion, Tom and Paul. But what you need is, you need to go to the bed and you need to look at your patient, and you need to look if he's deteriorating, even though he has the right antibiotics. And what about culture? And another question is, what PCR brings us here? So what's the impact of a PCR? And you probably have to put all together and discuss that on the bedside. And in the best case scenario, like me, you have a mycologist on hand, with whom you can discuss this. But it's tough.
Yeah. I mean, I've got a question, if I may, for you both, Simon and Paul. If we say we do have some multi-pronged approach to future diagnosis, what sort of study are we going to need? It seems to me that in these patients, you're going to need some sort of limited post-mortem to have to really know and do a proper study to thoroughly assess a new treatment approach. Is it possible to have some sort of multi-center study whereby you have limited post-mortem targeted lung biopsies of patients who die, or can we make progress without that?
I can answer first. Thank you for the question, Tom. So I'm pretty new in the business, but it strikes to me that we're not getting any further in recent years when it comes to diagnosis in terms of biomarkers, and I'm not sure if this is the right track. Even do more research in biomarkers, but because in the end, I mean, that's my opinion, you don't know if it's a true infection or not. Even if you have a new biomarker, you know there's Aspergillus in the patient's lung, but you don't know if it's invasive or not. So I'm looking more to that what Paul says, that we need studies looking at host defense mechanism. But that's a hard thing to do multi-centric, because we first need to establish, let's say, a proper pathway to look at before we do that in different centers.
Okay.
Yeah, I agree, but on the other hand, you need some kind of gold standard in the end to know, did this patient have an infection or not? And I think, thinking about having these limited post-mortem biopsies, I mean, that might be a way forward, because, full autopsy is often precluded, but maybe we could develop that area that in patients we could do a post-mortem biopsy from the lung to see if we can really validate the data we collect on the biomarkers.
It would have to be a really multi-site effort, wouldn't it? I mean, obviously, to get sensible data.
Yes. So you have a sampling error, so you might have to do imaging or some other approach.
Oh, sorry. So I'm sorry. I meant multi-hospital. Involve many.
Yes, of course,
groups.
yes, of course, because I mean the number of cases is too limited for a single hospital. But I think it's important for the community to think about these alternative ways to get proven disease in diagnosis.
Okay, listen, we've got a couple of excellent questions in the chat, so let me try these on you, Simon. Could you comment on the lack of neutrophil dysfunction in your ECMO work in light of the literature showing dysfunction after dialysis?
Thank you for the interesting question. No, I don't know. We did the experiments in other granulocytes like eosinophils and basophils and macrophages, and still we didn't see a difference. But I have to say, we just looked on migration. We did not look on reactive oxygen species, chemotaxis, whatever they do. We just looked at a very single function of neutrophils on migration, and there was no difference. But I can't tell you why.
Okay, fair enough. What about another question? Sepsis-associated Aspergillus in ICU. Is it a nosocomial infection? Which preventable measures could you use to avoid it?
Interesting question. I mean, first of all, that's for sure. It comes all to the sepsis measurements. So, as I always tell students in classes, sepsis is an emergency. So we have to get the diagnosis of sepsis firsthand. But that's an interesting question. As in our patients, what do you do when this patient is in septic shock? How do you prevent that the immune dysfunction develops? I don't have an answer to that, because we don't have any medication, any drugs just to reverse that. A lot have been tried, but as today we don't have any weapon for that. The thing is, I mean, on our center, I don't know how you do it in your institution. we do a lot of sampling. I mean, we do a lot of galactomannan, we do a lot of PCR studies when we think this patient might have a problem. And if you do more sampling, if you're allowed to do that, because it costs a lot of money, and that's probably a good thing to do it if you just do sampling. No?
Do you have a take on that question, Paul? I mean, in your case, Simon, it was already there day 2, so I guess he got it before he arrived into hospital. But in other cases, maybe it is nosocomial. What do you think?
Yeah, I think that it also depends on the host. I mean, we know in influenza we see that these infections are there very early, so it could be that the exposure already takes place prior to admission to the hospital, and depending on the immune status, the clinical disease may appear later.
Yeah.
So I would estimate that most patients take their Aspergillus with them from their environment before admission.
Okay, we've got quite a few questions still. Does the galactomannan index vary among different Aspergillus species?
That's an interesting question, and to be honest with you, don't know the answer and have to look to Paul.
Yeah, I think that's a difficult question. I know in vitro that you can see differences if you just test them in vitro, but I think in Europe we are very much dominated by fumigators, and I think in clinical practice the amount of galactomannan you find depends much more on the stage of the infection, and I don't think that the different species have a major impact on the levels that you find.
Paul, did you have any other questions you would like to raise?
No, not at this moment.
Okay.
I think the AI approach is interesting, although it seems a bit optimistic.
Yeah.
But I think, looking at the breath and see if we can get around doing all these bronchoscopies in these patients, I mean, that would also be a major advance in the management.
Yeah. I mean, the exhaled breath sample, I mean, that's quite a well-known technology, isn't it?
Yes.
Yeah. Okay, well, listen,
I wondering, Tom, can I ask a question?
Yes,
I can't
of
do
course.
it in the chat because
Please,
I'm on this panel.
Please, Adelia, go ahead.
Thanks, Simon. I found your work on the granulocytes, the neutrophils, very interesting, and was just thinking, knowing that, and I know there has been done a lot in kind of sepsis to maybe boosting immune responses. Do you think there is any place for critical care patients to search for how can we boost the neutrophil function to prevent secondary infections or infections like Aspergillus in your case you presented?
I mean, theoretically, that should probably work. But before we talk about this, we need to find the key problem where this Aspergillus defense, or let's say what stage of Aspergillus defense is hampered before we talk about that. But I think that's an interesting thought to do.
Yeah, because also there is some literature in influenza where the granulocytes or the neutrophils are less active or producing less ROS, what is a key defense mechanism. So I just thought, could we think about something? And yeah, I agree with you. You need to find a target and not kind of getting hyperinflammation, what you probably also not want in a critical ill patient. So it needs to be very kind of a delicate approach, but yeah,
exactly.
okay, thanks.
Okay. Okay, Adelia, any other points, or do you think we should wrap up at this point? We've had.
Yeah, I think it's good to wrap up, Tom.
Well, thank you very much, Simon. Thank you for audience, and thank you for the questions sent in. Thank you very much, Paul, for helping with some answers, at least. And we'll look forward to seeing everyone at the next MycoClinics in 3 months' time. Yes, Adelia? Okay. All right. Goodbye, everybody, for now.
Thank you. Bye.
Thank you. Bye-bye.